and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning. What is happening, man? I hope you guys are doing fantastic on this Tuesday. This is the first time I've done this with the new bizarre re-forwarding thing with StreamYard, because I don't know if you guys know this. This is one of the reasons that the show was down for several weeks. Was because Facebook and StreamYard, I don't know, had some kind of thing where third-party apps can no longer stream to groups. Doesn't make any sense to me. A bunch of control freaks, but nonetheless, we're doing a workaround and we got it fixed. Joe had to train me on it, but we got it all running now, and this show will hop now every Tuesday again, 9 a.m. live. So if you are with me, drop some comments for me so I know you're there. Let me know where you're tuning in from. But we definitely got a good show for you. I got some good news updates in the Medicare space that I want to go over real quick. Nothing super significant, but a few items that are definitely noteworthy. And then we're going to go through a lesson in bundling for your T65 prospects. Very simple concept, I promise you. I think a lot of people really overcomplicate bundling products. I mean, the best time to bundle, the best time to cross-market is in that very first conversation when you already have them on the phone. You already have their interest, right? But trying to sell someone one product at a time, right, in a cross-marketing fashion is going to make it much more challenging for you to effectively cross-market. So I'm going to show you a really simple way that you can bundle, stack a bunch of products into a simple T65 presentation that's going to maximize your ability to do that. So bear with me a little bit on some of these things. I'm still kind of getting the hang of this new format that we're doing as far as how we're getting this streamed into the group on StreamYard. So if you got any comments, drop them. You got any questions, drop them. I don't have the ability to display comments or statements or questions on screen anymore, but I've got an app over here running where I can see them and I can address them as you come up. So thank you guys for tuning in. Mary, Moises, Franco, Ray, Kayla, always appreciate you guys tuning in. So thank you much. So without further ado, let me I want to grab something for you guys real quick. Bear with me just a moment. Share screen. Boom. Medicare just recently dropped their 2025 physician fee schedule. Don't know if you guys saw this. Came out just short of 2 weeks ago, right? Came out on July 10th that they put this out there. And it's a pretty deep fee schedule proposed rule. And it is a proposed rule. This isn't a final rule, right? So there's still going to be some arguing back and forth on whether or not it's going to go into effect exactly like this. This has nothing to do with the CMS final rule previously that's over compensation and all that other stuff. This is just the Medicare physician fee schedule proposed rule. And it is lengthy. I am not going to go through this whole thing. I'm just going to show it to you real quick to see how lengthy it is. I will make sure that this is in the group so you can check it out. Everything in this proposed rule is all about payment services, payments to providers. Some of it is the amount that they're paying. Some of it is the process that they're paying, et cetera, et cetera. But you can certainly go through to see how big it is. They are making some major updates to provider payments for 2025, or at least they're proposing some major updates to provider payments. So lengthy. I'm going to point out two items in it that are specifically notable. The first one, the most important one, in my opinion, is the actual fee schedule. And here it is right here, right? They are looking at doing a reduction of 2.93% right here. By factors specified in law, average payment rates under the PFS, that is physician fee schedule, are proposed to be reduced by 2.93%. That's just shy of 3%. Now, reducing the doctor's payment by 3% doesn't sound like a lot of money, right? It's probably really not that significant. But the problem is this trend has been going on for a while. And I'm going to address that in another article for you. But just understand, again, and this has been a trend for several years now, again, under original Medicare, provider payments are going back down, right? They're going down again, 2.93%. Doctors are not happy about it. I'm going to show you an article on Kiplinger's from the AMA, or not on Kiplinger's, but from the AMA, American Medical Association, that goes over a lot of that. So stay tuned with me for that. But yes, doctors are getting paid less on original Medicare. This is another reason why Medicare Advantage has been thriving so much over the last decade or so, is because every year, provider payments on original Medicare continue on a downward trend. Provider payments on Medicare Advantage continue on an upward trend, especially when you look at the merit incentive-based payment structure that they're utilizing with value-based care and some of that, which we're also going to talk about because they're pushing that some more too. And that is right here in ambulatory specialty care. This little paragraph here says pretty simply, CMS is issuing a request for information to solicit feedback on the design of a potential ambulatory specialty care model that would leverage the merit-based incentive payment system, MIPS, value pathways. Now, MIPS came out, if I remember correctly, that was in the MACRA bill. I might be off on that. They may have done that before. I don't have all my stuff in front of me. But MIPS was created a long time ago, merit incentive-based payment structure. That is the legislation or the program that set the platform for value-based care to begin to thrive. Because the MIPS system, merit incentive-based payment structure, is based on doctors improving the outcome of your ailment, whatever it might be, your chronic disease, acute disease, whatever's going on. Whatever it is that ails you, right? If they can improve the outcome, if they can actually cure you, heal you, make you feel better versus just stuff you full of drugs, slap you on the ass and send you out, they get more money, right? And that has been one of the biggest growth things going on in value-based care. And they're going to push it some more. So what they are now doing, right, it says here, they are going to increase the engagement of specialists in value-based care and expand incentives for primary and specialty care coordination. So, and this is the whole purpose behind value-based care, right? They're supposed to be able to coordinate these doctors to better take care of you, right? If you saw some of the stuff that I've trained on and talked about in the previous, I talked about how value-based care actually came out, I want to say in the 60s or 70s, if I remember right. I might be a little off on that date. I don't remember it exactly. But value-based care came out a long time ago, specifically for chronically ill children who had a bunch of doctors that were disjointed and then needed to better coordinate this doctor talking to this doctor and communicating with each other so they all know what's going on and one doesn't prescribe a certain treatment that might give a counter-producing result from what the other doctor is doing, right? They're all working together. Makes sense to me, right? So that's kind of where value-based care came, and now they're pushing it harder, saying, hey, if primary care physicians and specialists can improve their coordination of care, we're going to expand the incentives, the payments to those doctors, right? So again, they're pushing merit-based incentive payments. They're pushing incentivized payments to doctors that improve your actual sickness, illness, chronic disease, whatever it is. They're trying to improve the outcome of your ailment. And if they do so, they get paid more money. And they're even saying now that if these primary care and specialty care people can work better together, can better coordinate care to improve your system, they're all going to get a better payment. That only exists for the most part in the Medicare Advantage world. Some of that certainly exists in the original Medicare space, but most of the value-based care centers that we're aware of, they all favor Medicare Advantage products. Do they take original Medicare? Yeah, they don't really like it though. Ask them. Go into Suvita, go into Oak Street, go into some of these people and ask them like, hey, will you guys accept people that just have original Medicare with a supplement? They'll say yes. Some of them actually, I think will even tell you no. But they'll say, yeah, but we'd really kind of prefer them be on a Medicare Advantage plan. Why? It's always about the money. I have a new guy here in my office. He loves to ask me the question, why? And invariably, the answer is simple. It all comes down to money. Right? People make their decisions. Professionals make their decisions. Doctors make their decisions. The government makes their decisions based on money. Fairly simple. So those are the 2 points that I really wanted to kind of stress, right? Again, payments to original Medicare are going back down. Payments to Medicare Advantage and value-based care are going up. And that's why I continue to stress that my belief on the future of Medicare is definitely going to be in a Medicare Advantage type world where value-based care is the number one platform that we're utilizing. I truly believe we're headed that way, and I think that is going to be their gateway to probably some form of universal health care. That's just me. So I'm going to post this in the group. You guys can go through it and see all the different provider payments that they're looking at. You might find some other ones that are interesting to you. I went through it in pretty good detail, and those are the two that stuck out to me to help me kind of understand where this thing is going, so to speak. So there is that one. And then now I want to give you the other side of that argument a little bit. I'm going to show you this article here that I will also get in the group. This is from the American Medical Association. And it says that Medicare physician payment reform has never been more urgent. This just came out this week by Bruce Scott, Dr. Bruce Scott, the president of AMA. So I'm not going to go through this whole article, but the basic concept of this article is they are bitching about the fact that original Medicare provider payments are going down. And they talk about it right here. It says right here, hey, this is the 5th straight year that Medicare payment reductions for physicians. And it continues a devastating 2-decade decline that has pushed many practices to the brink of financial collapse and threatens access to care for our nation's elderly and disabled population. That's a wee bit hyperbolic in my opinion, but they're not wrong. Like, provider payments to original Medicare have been going down. And as a matter of fact, if you look back all the way since 2001, 23 years ago, it will tell you that physicians have experienced a 29% drop in Medicare payment services. 29%. Doctors are getting reimbursed 29% less in 2024 than they were in 2001. Now, I don't have to tell you that healthcare's gotten more expensive in those 23 years, right? Everything has gotten more expensive. The price of all of the equipment that they need to take care of you, right? All of those things have gone up in price, yet doctors are making less money. It surprises me to some extent that 99% of doctors still accept Medicare, considering they're making 30% less than they were making in 2001. I'm surprised that the stat is still solid. 99% of doctors accept Medicare, but they're accepting it in a glib light. They're not happy about it, right? And you can certainly go through this article. I will put that on there. He speculates on some common sense fixes and so forth. And again, they talk about because they have a counter proposal here with HR 2474, House Bill 2474, and they have a proposal again to push merit-based incentive payments more relevant in original Medicare as well. So they are looking for those merit-based incentives on original Medicare too. It's certainly bigger in the Medicare Advantage and value-based care world, but there it is. I'll get this article in the group for you. You can read through it, hear these doctors' complaints, and see what they think might be better in regards to reform. Guido Pinto says, morning, Tony. I used to have a medical billing company years ago, and one of the major complaints from medical providers was the fee schedule. Absolutely, man. Doctors, man, they like to drive their Porsches and their Jaguars and their Mercedes. That 29% fee cut is not going to go over well. So a couple other details, and then we're going to jump into the stuff. This is another fact sheet from CMS that just came out. I'm sure, as you guys are probably aware, because you're all educated professionals, next year, the payment, the Medicare prescription payment plan is available, right? That kicks off in 2025. This fact sheet that they just put out goes through some basic Q&A. I'm not going to go through it all, but I will get it in the group. But if you're not familiar with what the Medicare prescription payment plan is, it's very simple. For those that have a high cost in prescriptions, they will be able to spread that annual cost out into monthly installments, where every month they have kind of the same expense. Because as you know, as you probably worked with some clients that have some major drugs, depending on the plan you put them on, in a lot of cases, that first couple of months are really expensive because they got to meet the deductible phase. They got to go through the initial phase before they start to get into the gap phase and maybe even the catastrophic phase. Obviously, donut hole is going away next year as well, and they're going to cap everything at $2,000 for total out-of-pocket expense for drugs, which basically means for any of your clients who are going to max out their $2,000 of formulary covered co-payments on their scripts, instead of having to fulfill a massive deductible in the beginning of the year and then it tapers down over the year, they can just say, hey, I'm not paying anything when I go to the pharmacy. I'm going to let the insurance company, the provider that I have my Part D plan with, spread that out over 12 months, and I'll make monthly installments. Pretty simple, right? It doesn't surprise me that in a world where we are used to financing everything, buy now, pay later, that they're now doing that with our prescription drugs. They're giving you a chance to buy now, pay later. I think it'll definitely be a very useful platform for people to help people out, right? To better manage their budget. And for, when you're working with some of these folks that are obviously on a fixed income, that can come into play. That can be extremely important for folks. So I definitely think that'll be a good one. I'll get this in the group for you. And then finally, one last item. And this is something that I hadn't even thought of myself. This is an article I found in Kiplinger's. And it talks about how the Medicare upgrades that are happening next year could actually disqualify your private plan. They're talking about your group insurance plan. So it's no big secret that people that are turning 65 today aren't always retiring at 65, right? The price of goods are expensive. The middle class is getting squeezed. The lower class is even worse. So there's a lot of people that are working past 65. They're not retiring until they're 67, 68, 69, even 70. I don't think my dad officially retired until he was about 72. And even then, he wasn't really retired because he was still working consulting jobs on the side. But the truth is, most of them are working later, which means there's a lot more people that are delaying Part B. They're keeping their group plan, right? And they're able to delay Part B and Part D, as in dog, because they have creditable coverage. But the rule is this, and I'm specifically going to talk about Part D because that's what this talks about. The Part B side of it doesn't necessarily matter. But the Part D side, in order to avoid the late enrollment penalty for Part D, your private group insurance plan must provide drug benefits that are at least equal to, if not better than, what Medicare offers. Okay? Well, here's the skinny. As again we know, and this article lays out, next year there is a $2,000 out-of-pocket max on your scripts in Medicare. That's better than most group plans. That's better coverage than most group plans. So there is a good chance that group plans that don't have a $2,000 out-of-pocket max on your prescriptions will not be considered creditable from the Part D late enrollment penalty. Yeah, you heard me right. I hadn't even thought about this problem that they're now creating, but this is another piece that we're going to have to look at when we talk to our consumers that are looking at delaying Part B because they're still working, they're still getting their group insurance, and they like it. But if their drug plan does not include an out-of-pocket max of $2,000 like Medicare will, then they will likely, most likely, be subject to the late enrollment penalty for Part D, which, as we know, is 1% for every month. Is that right? Yeah. I keep forgetting all this stuff. There's 1% for every month. And it goes through this a little more in detail. I'm not going to go through this because a lot of this is information that you guys already know as professionals. But that one piece right there, with improvements coming to Part D going into effect January 1, some employer plans that qualified as creditable because their benefits were at least as good as those offered by Part D before the changes, well, they may no longer be eligible. For instance, and it goes through the whole thing that I just said. So if your private plan does not cap out-of-pocket drug cost at $2,000 or less per year, then it may not be sufficient to avoid the Part D penalty. Food for thought. 2025 is going to be a wild year. So, all right, with that said, boom, I hope you guys are excited and ready for this because I'm going to show you guys. Yesterday I had an appointment, came into the office, and there's a new script that I've been working on and wanting to teach my guys, but I haven't rolled it out to them yet because I needed to prove it. And it's been a long time since I've regularly written business. Over the years, I've always written a little bit of business, but most of it has just been friends, family, and the occasional referral. Maybe write 15 or 20 apps a year at most. Now that I'm left the wholesale space and I'm now running an agency, obviously personal production is falling in my lap a little more often. I do not market for myself. All my marketing is for my team to help them out. So generally, I'm still only writing referrals. One of the big reasons I joined BNI was so that I can kind of start rebuilding my book of business through a referral mechanism, but also hopefully find some referrals in some larger formats that I can give to my team. But nonetheless, I had a referral come to me, and he was here in Cedar Park, wanted to come in the office and meet with me. And great conversation, great guy. And at the end of our conversation, I wrote 5 applications for him. I wrote him a Medicare supplement plan. I wrote him a drug plan. I wrote him a dental plan. I wrote him a vision plan. And then I wrote him a short-term care plan, home health care plan. 5 enrollments, 5 apps, 1 appointment. And I'm going to be 100% honest with you. In our entire conversation, I never pitched one single product. Not once. Never even pitched a product. All I did was I explained what he has with original Medicare now, and then how we plug the gaps, how we solve the problems, so to speak. I'm going to go through that exact conversation. I'm going to write it out for you. There are a couple of prerequisites in order to have a conversation with a turning 65 prospect at this level. There's a couple of requirements. The first requirement is you got to have your scope of appointment done, because you need to be able to walk into this conversation clear to immediately start talking benefits, rates, product design, etc. Okay, so you got to have your scope of appointment already done. You also need intake already done. And with the 48-hour rule of scopes, like, it shouldn't be that hard. Like, it bugs me that people are complaining about the 48-hour scope rule, because truthfully, the 48-hour scope rule is teeing you up to make massive sales if you know how to negotiate it properly. It's simple. Hey, John, real quick, I'm going to send you this consent form, scope of appointment. It outlines our scope. I'm also going to include some intake questions that will help me get started on your case. I'm going to need about 48 hours to go through all that information and compare plans. Let's set an appointment. Give me a couple days later and set your appointment, man. And then that time you're going to do a little bit. Obviously, it doesn't take you 48 hours to grab their information, look up plans nowadays online with all the stuff that we have, and come up with recommendations. But because you're already required to delay that second, unless they're a walk-in or a call-in, yes, I understand all that. That gives you the opportunity to play it this way, to spin it, right? As, hey, I need 48 hours to research your plans. Let me do all the shopping for you. And when we reconvene for our appointment, I'm going to have some great suggestions for you. Fairly simple like that. If I'm you right now, I would go get a pen and a pad of paper, probably 1 sheet really, because I want you to follow along with me. I'm going to type it out in a Google Doc on the screen share. Let me share that again real quick. Because as I talked to this gentleman, I sat down right next to him. Come on, share the screen. I sat down right next to him and documented exactly what I'm going to document for you guys, right? So this is in this particular instance, it's a face-to-face appointment, and I wrote down exactly what I'm going to show you guys in the exact order, the exact words that I gave it to him, and I'm going to show you exactly the closing question that I gave him to get the 5 applications that I wanted and that I needed. And you can ask my wife this. On Sunday, before I had that appointment yesterday, I called my shot. I told her, I'm like, hey, I'm going to write 5 apps tomorrow. You should probably watch this appointment because it's going to blow your mind. And unfortunately, they were all busy, so they couldn't watch. But I told them about it, and now I'm going to teach them about it. If I'm doing this by phone, it can still be done by phone. I promise you. The difference is you have to tell your client, hey, Margaret, go do me a solid. I'm going to go through some details. I want to teach you exactly what that red, white, and blue card is that you now have, so that you understand how to use it, how it works. So I need you to get a pen and paper, because I'm going to tell you some specific notes that are very important. I want you to write down. Fair enough? Fair enough. And she says, great. So again, this is based on a T65 presentation. This is brand new to Medicare. They got their Medicare card and they are ready to go, but they have no clue what to do, right? This isn't plan review. This isn't AEP stuff. This is turning 65. Turning 65 is my bread and butter. It is what we market to day in and day out. We write about 20 to 30 new T65 clients every month in this office. That is the gravy train, and that's my focus. So, and I would encourage you to make it your focus. But this is a presentation that's going to help you maximize your risk mitigation, because that is our job as an insurance agent. Our job, our responsibility as an insurance agent is to ethically and compliantly resolve as much risk as we can for the client to protect them and put them in a good place, right? So this is going to give you that ability to maximize the ability to cover as much risk as you can for your client. It's going to give you a chance to write more apps, which is going to increase your sales and your commissions and your revenue. It's also going to increase your customer attention, because we already know the statistics. If you have more than 2 applications, it's actually 3. You need about 3 apps. If you get 3 or more applications or policies on a single client or single policy holder, dude, they ain't leaving you. There is no way in hell that any other agent is going to walk into this guy's house or get this guy on the phone and pull him away from me. I've got 5 policies with him. He ain't going nowhere. I got that dude locked in for life. And that's ultimately what you want, because that's what makes this business hyper lucrative. Like, you can suck in this business and write an app, couple apps a day, or a couple apps a week, a few apps a week here and there. And all you're writing is some Medicare Advantage or the occasional Med Sup and drug plan. And that's all you do. You can definitely make a great living in this business doing that. Just going to take you a little while longer. But if you learn how to bundle, you learn how to cross market, you learn how to take care of your clients at the highest level and maximize the amount of risk that you're mitigating, you can make this business hyper lucrative. Just ask my 2 buddies, Josh Lustig, Justin Brock, right? One great example about my buddy Josh Lustig, he was only selling Medicare supplements by phone by himself. He's writing about 50 apps a month. And then somebody said, hey, you should cross-market dental. He's like, hey, that's a good idea. And he added 1 product to his cross-market. He increases revenue 37%. And if you know Josh, you know that he just made a nice 8-figure exit. So cross-marketing works, bundling works, and I'm going to show you how it's done. So I'm sitting with my client. They are brand new to Medicare. All they got is the red, white, and blue card. In this particular instance, this gentleman actually turned 65 in September. So I'm way ahead of the curve, because that's, again, how I try to operate. I want to catch these people somewhere around 4 to 9 months outside of their T65th birthday, optimally. I mean, if they call me the month before, I get a hold of them the month before, that's great. Still going to take care of them. We just got to move a little quicker on some things. But generally, I am trying to get out way in front so I can educate them, empower them, and get them ready for the big transition. So understand a couple of things. I've had 2 conversations with this gentleman before the conversation I'm about to explain to you. The first conversation was when he found me. I don't know exactly. Someone in Florida that I don't know recommended NABIP to this guy's sister, and she surfed on NABIP because he lives in Austin. And then somehow they found me, called me, and I warmed them up real quick with the brief education, set an appointment, and then he came in the office and I helped him get through the Medicare enrollment process. He needed to apply for A and B, so I walked him through the steps on that online. We banged it out, and then I gave him just a very brief education on Medicare. Just a brief one, so that he understood what he was enrolling in pretty simply, right? 2 weeks later, he calls me up and he's like, hey, I got my Medicare card. What do I do now? I'm like, well, let's schedule an appointment. Let's come in and talk about how that card works and what we need to do to make sure you have the right health care for you. Fair enough? Cool. So I've already got my scope, because I did that before the appointment long ago, and I've already got an intake form on him. So I know exactly who his doctors are. I know it's exactly what drugs he's taking. And I know some general questions about him, because my intake form, I use Retire Flow. So it asks, there's a couple of cool questions that Retire Flow asks. One of my favorite ones that it asks, and I don't know the exact wording on it right now, but it's something to the effect of, hey, would you prefer freedom of choice, even if it comes at a little higher price? Or would you prefer a network-driven low premium plan that may have more co-payments in it? Something to that effect. And that question is awesome, because it tells you right up front, oh, is this person going to lean towards Medicare supplement with original Medicare, or are they more of a Medicare Advantage prospect, right? And so some of that information is super pertinent to make the type of conversation that I'm about to have with this guy. And I promise you, it doesn't matter if your prospect leans towards Medicare Supplement or leans toward Medicare Advantage. Doesn't matter. Either way, this works. I promise. The difference is you just have to tailor what you're going to say to meet. Am I talking to someone that's MedSup and original Medicare? Or am I talking to someone that's likely MA? Right? And again, that comes with good discovery, good intake. So I knew the guy's doctor's drugs, his situation, and I knew that he's probably favored Medicare Supplement. Piece of cake. So I'm leading in that direction. So he comes in, hey, Glenn, how you doing? Yada, yada, yada. We sit down. And I'm like, look, I want to sit side by side because I want to go through some details. I want to make sure you understand exactly how that red, white, and blue card works. Fair enough. And the first thing I tell him is that now what's most important to understand is that Medicare card is actually really good insurance. I want to build that up. I don't want to tell them that Medicare sucks, because it doesn't. Medicare in and of itself, that red, white, and blue card is actually really damn good insurance. So I build it up. I'm like, okay, is that red, white, and blue card you have there? That's really good insurance. Why is it really good insurance? Well, it's accepted by 99% of providers in all 50 states. And I'm writing these things down right in front of them, just like I'm typing them out for you to see. Right? So with that card, you can go see any doctor you want in all 50 states, even Puerto Rico. You don't need referrals. You don't need permission. All you need to do is make an appointment with any provider that accepts Medicare. True freedom of choice. Do you understand that? He's like, that sounds great. I was like, but it does have a problem. It works like an 80-20 plan, which basically means that for any hospital or medical bill that you have that is medically necessary, Medicare is going to pick up 80%, and you are on the hook for a 20% coinsurance. Now, here's the 20% coinsurance, and I stopped there for a second. Now, also, you don't have any drug coverage, you don't have any dental coverage, you don't have any vision, and you don't have any hearing coverage. I'm writing all this out in front of him just like I'm writing it for you, right? That's what that red, white, and blue card gets you for the most part. It gets you access to 99% of providers on an 80-20 plan. You're on the hook for 20% coinsurance, whether it's hospital, medical, doesn't matter. And you also do not have drug coverage, dental coverage, vision, or hearing, all right? So that 20% coinsurance, let's understand how that works, right? So a doctor visit, no big deal. Average doctor visit in Texas is about $250, which means your copayment's $50. Not a big deal. But let's look at the hospital stay. Average hospital stay in Texas is 3 days and is pushing $15,000, which means your 20% is now $3,000. Now, that's some basic stuff, right? That's doctors and hospitals. Now, if we look at something more serious like cancer, heart, and stroke, well, as you know, those are the three, as you probably know, Glenn, those are the three most expensive diseases to treat. And you're looking at co-insurance closer to about $20,000 for a situation like that. And then in the event that you are incapacitated or put into a skilled nursing facility where you need lengthier care because you don't have the ability to transfer yourself or whatever it might be, you're looking at co-insurance closer to about $100,000 a year, because Medicare doesn't cover much for skilled nursing, and it runs about $100,000 a year on average to stay in a long-term care facility. Now, good news is Medicare is going to give you 20 days of SNF for free. The next 80 days, 21 through 100, they're going to charge you a $204 copayment. And if for any reason you were in a skilled nursing facility longer than 100 days, you pay all costs. So, Glenn, as I've explained this, do you understand what I'm explaining to you? Do you understand that it's an 80-20 plan? You're on the hook for 20% coinsurance. That coinsurance is uncapped. I left that off on my writing, but that's what's one super important to say in there. And that's why these numbers down here start to make sense to them. So they're like, all right, $50 for the doctor. I can handle that. $3,000 for a hospital. Well, I can handle that, but I really don't like handling it. Might have to go on a credit card. $20,000 in co-insurance if I get something critical like cancer, heart, and stroke, which we know as you become 65 years old is a coin flip. Now you're looking at $20,000 plus in expenses. And that would even be similar. A knee surgery wouldn't be too far off of that. Knee replacement. I threw that in there as well. So something like a knee replacement, you could easily be looking at $20,000 in co-insurance. And then obviously, worst case scenario, if we're really in bad shape and we got to get put in skilled nursing so that we're watched and taken care of, this is what we're up against there. And that's exactly what I showed him. I was like, so I want you to understand this is what you're up against. And I apologize because I forgot to write this on your sheet. You have to hit this at the top. My apologies, y'all. I'm doing this by memory at the moment, not from the worksheet I already had. But so it's really good insurance. So I make sure that he understands first and foremost, you have a $174.70 premium. You're getting 99% of providers. It's an 80-20 plan, 20% co-insurance. It's uncapped. You still don't have drugs, dental, vision, or hearing. And when we look at the 20%, here's some real world examples of what your 20% looks like. So this is all an example of Greg Gerbikian's famous statement of selling the problem. I'm not selling the solution. I'm selling the problem. This is the problem. This is what you're up against, Glenn. Now, what I can do for you, Glenn, because I've already done my research, I designed a healthcare package for him. So I draw a line on my page underneath that section. And then I say, here's what I can do for you. I can take all of your hospital and medical, and instead of it being a 20% uncapped co-insurance, I can reduce it to a $240 annual deductible. And then his eyes light up. It's called a buying sign. When you see people nod, when you see people light up, when you see people go, oh, those are called buying signs. Buying signs are good. Buying signs are what you want. Buying signs usually mean that you should just shut up and close the sale right now, but we're not there yet. So I tell them I can take all of these problems, this 20% co-insurance, and I can reduce it to a $240 annual deductible. And then I further tell him that annual deductible is for Part B. It's for doctors, lab work, blood, x-ray, whatever you need, right? And in most cases, it's going to be paid in piecemeal, somewhere to $30 to $50 a pop, until you hit 240. Does that make sense, Glenn? He's like, yep, makes complete sense. Perfect. Now, if you hit that $240, you're going to maintain a $20 copayment for additional doctor visits in that year. Doesn't matter if it's a primary care specialist. By the way, Glenn, how often do you go to the doctor? Currently, I only go once a year for my physical. Okay, so you probably won't even reach your deductible. But just so you know, in the event that you do, and you have more doctor visits, we're going to cap them at $20, and you get unlimited doctor visits. Now, there is one other copayment that I have to tell you about, and that is a copayment for ER. You have a $50 copayment for emergency room. And let me explain how that works. If you go to the emergency room, let's say you cut your hand open really bad, you need stitches, you walk in, they stitch you up, send you home, that's $50. And that goes towards your $240 deductible. Now, if you go to the ER and they're like, hey, Glenn, we're going to need to keep you overnight. You don't look so good. Now, it's no longer a $50 copayment for ER because it moves to inpatient. So it's a hospitalization now. And the good news is, Glenn, my plan has your hospital covered 100%. Again, I get eyes light up. Buying sign. I'm on the right track with this guy. Okay. Makes sense? He's like, yeah, that makes great. Now, the bad problem is we still don't have drugs, dental, vision, or hearing. Now, good news for you, and this is my next statement's going to vary based on your client a little bit, right? Because again, I've already got all my intake, so I'm able to create my plan design before I ever talk to him, and I know what I'm going to pitch him, right? If I have someone else then I'm going to pitch a little bit differently. Still same concept. I'm formulating this for Glenn. So I say, good news for you. You don't have any major prescriptions, so we can wipe that out with a fairly simple 50-cent drug plan for you. The guy's only taking lisinopril, right? In other instances, I'm going to have to dig into this a little deeper, and my explanation is going to be different, right? But still the same concept again. So my good news is we can check that out for 50 cents, and you'll have zero refill cost at your favorite HEB pharmacy. All right? Now, for the rest of it, I can include dental, vision, hearing, and I can also add 360 days of S&F. And I can do all of that, Glenn, for $177.51 per month. Does that sound like the type of healthcare package that you want? And Glenn immediately is like, yes, it does. I'm like, perfect. Does that 177.51, or hang on. Does the 177.51 fit your budget? But actually, it's 174.70 plus the 177.51. And I made sure he was aware of that, right? So first thing I asked him, I get to this end, I'm like, so I can put all this together for you based on what I've just mentioned for 177.51. Does that sound like the type of healthcare package that you want? He says, yes. Excellent. Now, remember, you still have to pay your Part B premium. So in total, whatever that, it's like $352, yada, yada, yada. So your total healthcare expense per year or per month is $352. Is that fit within your healthcare budget that you expected? He's like, yes, it very much fits in. I'm like, perfect. We just got a handful of apps to do, and we'll knock them out in a few minutes. I jumped on the computer. We bang out some apps, couple of digital signatures. Guy walks out the door. Piece of cake. Like, I promise you, bundling does not have to be that difficult. There's a few things that you have to understand as an agent. And if you're a newer agent, this is especially true. And I'm going to say this, and I know a lot of people don't like it when I say this, but I'm going to say this. You are not under any obligation to explain every single product available to that person. You are not under any obligation to do that. You do not have to explain Medicare Advantage to a prospect unless they ask, or unless that's what you're trying to sell them. 99% of the clients or prospects that I talk to, I do not talk about Medicare Advantage unless they bring it up. There's a purpose for that. It's partially my own perspective. I believe that Medicare Supplement is the better product design. Obviously, that's not a hard and fast rule in every single market. If I'm in Miami-Dade County, hell no, I'm not writing Med Supps. I'm writing the $500 MOOP MA plans, right? But here in Texas, in many other markets where Medicare supplements are fairly inexpensive and MOOPs on MA plans are still several $1,000s, I still believe MedSup gives people a better option. And most importantly, just because of the freedom of choice, right? So when I present a client, I present just about everybody just like that. Now, if that guy balks and he's like, wow, 177 is a little more than I wanted. Well, I can do one of two things. I can immediately pivot to my MAPD bundle that I put together for him as my alternative because I had that ready, or I can peel back some of the benefits in the plan that I created. So if I'd asked him, hey, does 177.51 sound like, is that reasonable? Is that affordable for you? And if he says, that's a little more than I wanted to spend. I'm like, well, what, just so I can make sure that we're on the same page, what were you thinking or what were you budgeting for your health care? He's like, I was trying to keep it, around $125 at most. Well, then I can drop off the skilled nursing policy that I added on there, and boom, I'm writing 125, and I've still got him for 4 apps. I still get him for dental, vision, drugs, and MedSup. Or alternatively, I can flip to the MAPD bundles. I believe that it's your job to design your client's healthcare package. And you have to think about a lot of these people that are in the group world that are now navigating to retirement and they're navigating to Medicare. They're not just losing their hospital medical coverage. They're losing hospital, medical. They could certainly be losing some critical supplemental accident or insurance that they may have bought through an Aflac group rep or somebody that came through. They're probably losing their life insurance, their employer paid life insurance. They're losing dental. They're losing vision. They're losing hearing. They're losing all of those benefits. So why wouldn't you present them with a healthcare package that includes all those benefits? And if you're just going to tell me the emperor's response, yeah, Tony, I'm selling my Medicare Advantage plan, and it includes all those benefits. Great. But it includes all those benefits with a lot of out-of-pocket fees, costs, co-payments, co-insurance, etc. The biggest one being the 20% for Part B drugs, 20% for outpatient surgeries, things like that. Well, why can't you bundle something in with those products and pitch it that way? If you feel like your client or this prospect is going to lean towards Medicare Advantage, either based on your intake or your discovery questions with them, then just build your MAPD, right? So you're getting their intake form, you got their drugs, you got their doctors, you map it out, and you know this person's probably going MAPD. So map it all out for them. Pick the plan that you think is absolutely the best, whatever it might be. Pick that one plan that covers their drugs, covers their doctors, gives them all the benefits that you think are going to be the greatest for them, and set that package up. Hey, here's what we can do. I can take care of your hospital, your dental, or your medical, your dental, your vision, and I can reduce it down to this package right here. And it's going to include a simple Medicare Advantage plan that is an all-in-one plan for your hospital, medical, dental, vision, hearing. Also includes a few of the little niceties, but it has some gaps that I plugged in with the simple hospital indemnity plan. This whole package, Miss Jones, is going to cost you whatever. And if you're doing it with Part B give back plans, like, give me a break, man. If you're writing Part B give back plans and you're not cross-marketing that savings, you're missing the boat. And you're doing your client a disservice, just to be honest with you. You're 100% doing your client a disservice. You have to at least offer it. They can say no, but who cares? But if you're not offering it, then you're never going to sell it. If you're not offering it, then they're always just saying no. You're making an assumption that your client's going to say no. I see people not cross-market stuff to DSNP clients because they assume, oh, they're DSNP, they can't afford anything. In most cases, you're probably true. But we've got DSNP clients that have low-cost cancer policies with us, $25, $30 premium, just enough, gives them an extra $10K that they can throw at cancer if that happens, right? If you don't ask, you're assuming they're going to say no, and you're doing them a disservice, 100%. All you have to do is ask. And if you ask, and you ask everybody, somebody buys some. When you go to your favorite Mexican restaurant, that waiter asks you if you want guacamole. Now, that waiter has probably 5 to 6 other tables. If he doesn't ask every table if they want guacamole, he's going to be really sporadic. Some people are going to buy it. Some people aren't. I know this is like a really soft analogy, but it's blatantly true. That server, and I learned this because I spent many years in the restaurant and I trained restaurant servers on how to be really good at sales. You have to ask every single table, you guys want guacamole? Hey, you guys want margaritas? You have to suggest it. You have to offer it and let them say no. Do not assume that your client does not want it, can't afford it, doesn't need it. You're shooting yourself in the foot. I promise. Just ask. I'm going to make a worksheet out of this presentation. I liked it so much. It worked so well. I'm going to make a worksheet that you can use, that you can send to your client and have them follow along if you're doing it on the phone. If you're doing a Zoom call, then you can just do it in front of them, kind of like I did, pretty simply, right? But that's pretty much it, man. Bundle up front, right? Everything that I did, all I did was I pointed out all the problems, all the stuff that he's on the hook for, and the cost kept getting higher and higher and higher and higher until finally I was able to say, look, I can take this massive cost and reduce it way down here, and I can include this, and this, and I can do it for this price. Does that sound like the healthcare you want? Yes. Boom. Write it up. 5 apps. If I sell that any other way, I guarantee you I don't get all 5 apps. If I just write the meds up in the drug plan, and like now that we have that done, did you need any dental or vision? Like, nah, my teeth are pretty good. Can I wait on that? Do I have to get that now? Like now I'm dealing with friction objections and I'm making it harder to sell. And then I come back behind that later and I'm like, hey, I know you got your meds up and we got your drugs and I appreciate you buying that dental plan from me, but I wanted to go over, the shortcomings in the skilled nursing facility care that Medicare offers and try to get you some more premium now. They're being like, nah, I'm good, man. Do I have to get that now? Right? You're going to deal with friction. Get it all up front. Get it all up front with the conversation like this. I promise it'll work. I promise you it'll work. I'm going to make a worksheet. When I get the worksheet done the way that I like it, I'll share it with you guys because I love y'all. So I'll make sure that you guys all have a copy of it, and you can use that in your own presentations, whether they be face-to-face, whatever the case may be. But I promise you, if you pitch it this way, you'll sell more insurance. Guaranteed. Hope you guys had an awesome day. Oh, sorry. A couple more announcements. I'm super happy, number one, that Tuesday training is back. I apologize that it took me a couple of months to get this resolved. Also, I've been traveling quite a bit, so it's made it a little more difficult because my time has been extremely thin. But next week, we're going to have Norma Johnson on the show. If you guys do not know Norma Johnson, she is an absolute savant when it comes to prescription drugs. She knows everything there is to know about prescription drugs, how the PBMs are. She knows everything. I have never met a person in the Medicare industry, at least, that is more savvy on that than she is. So we're going to talk about prescription drugs. We're going to talk about the 12-month prescription payment plan, the Inflation Reduction Act, and help you guys really get a handle on what we're going to see next year when it comes to prescription drugs and how that's going to work, how it's going to turn out for you guys. These are recorded, Valerie. Yes, they are. They're in you can go in the group and under, I can't remember, I think it's the media tab, if I remember right, or media and then videos, and you can find every video we've ever shot inside the group. You can also go to our YouTube channel, Insurance Syndicate YouTube channel. You can go there. You can find every video that we've got. You can certainly rewatch them, run through them all you want. Absolutely. Share them, please. Post them. Love them. Shoot me some stars, all that stuff, right? Next announcement, stay tuned. For those of you who have been holding out for my Facebook ads course and ads training that is coming out very soon, I promised y'all that I would have it somewhere between late July, early mid-August. I'm right on schedule. I ain't going to let y'all down. It's going to be a fat training. It's probably going to be a 2 to 3 hour training class. It's going to go through a lot. I'm going to go through the basics. I'm going to preface it with some advertising 101 to give you some basic concepts of advertising, why certain things work and why they don't, and how that translates to Facebook advertising. We're going to go through the Facebook ads platform, the entire structure of it, to make sure you understand what you're looking at when you're in the Meta ads universe. We're going to talk about how to create a campaign, an ad set, and an ad. I'm going to launch a live ad. I'm going to create a campaign, ad set, and ad right in front of you and launch it right in front of you. And then, we're going to talk about converting, how to convert those leads on Facebook. There's a lot of ways you can convert them, whether it be through a landing page, through Messenger, through a phone call, through Insta forms. I'm going to go through all that. So it's going to be a deep course. Stay tuned for it. I'm finishing it up. I'll have it ready to go. It will go live just like this one for anybody who wants to tune in live. I'll also record that one and have it available for post-production. So stay tuned. I will be making some announcements for that very, very soon. Other than that, man, thank you guys for tuning in. This has been another great Tuesday training. I'm super happy to be back. And, man, I'll see y'all next week. 9 a.m. right here, always live, always in the Insurance Syndicate. And I also push this out to my LinkedIn page. So if you'd rather follow me on LinkedIn instead of the group, your choice, but I'm there both times. And, we'll see you next week with Norma Johnson, man. You guys have a great week. Bundle it up. See ya.